when you're talking about using a movement screen, it's not that I think that the movement screen is not a good thing to do. It is a very good thing to have. It's a good tool to utilize. It's just the interpretation of the movement screen where we have a problem. If you get someone to, use the example of a squat. If you get someone to squat and you see something in their squat, they're unable to squat with their arms over their head, something's wrong with their squat. What you should not do is look at the movement and say, okay, you're unable to do this, here are some exercises to correct the movement. Don't try to correct the movement before you've determined whether or not the articulations involved in that movement are able to do what you're asking them to do. If someone gets you to squat and you can only go this far, if I sit there and yell at you to go deeper, that's not good coaching, because you haven't determined whether or not your patient client has the available mobility in the articulations involved in that movement to do what it is you're asking them to do. If you say go lower and they forcefully go lower, if they have, let's say, a mechanical restriction in dorsiflexion of the ankle, you are forcing dorsiflexion of the ankle under load. What do you think is going to happen? They're going to get injured. So even though you might screen a movement, you still have to get them on a table and you have to assess the mechanical quality of their tissue to determine if there is a mechanical reason why they cannot accomplish a certain movement. A movement is a combination of a neurological deployment of a strategy to move, but that strategy can also only occur properly if the articulations have the available ranges that you need to have that movement occur. So whatever you see in a screen, you still have to assess whether or not those joints are able to do it. If you're looking at a squat, you got to get the person on the table. You got to see if there is mechanical restriction to ankle dorsiflexion, knee flexion, hip flexion, lumbar spine extension, thoracic. All of that needs to be assessed. If you're trying to get someone to squat with their arms over their head, if they have a capsular restriction in their shoulder, don't just give them exercises so that they can forcefully do this. You need to possibly normalize that articular function before you give them exercise to fix that pattern. The other thing you have to consider is, if you tell someone to do a particular screen and they're unfamiliar with the movement, of course they're not going to do the movement properly because their nervous system is unfamiliar with the movement. If I asked you to do a handstand right now, could you do it? Because you can't do a handstand, because I'm asking your nervous system to do something that it's unfamiliar with. If I told you to squat with your arms over your head and I gave you a couple days to practice and then I assessed it, that gives you a pure representation as to whether or not they can do it or not, because the nervous system had chances to adapt to the movement and do it. How do we learn movements? You learn movements by teaching the nervous system how to do them. Give someone an unfamiliar movement, they're not going to do it properly, right? So when you're doing a screen, you really have to think about what you're actually seeing. Are you actually seeing a restriction? Are you actually seeing a problem? Or are you just seeing the nervous system's interpretation of the movement?